So we have been for almost 3 months reviewing the radiology of the stomach. And last time we started to review radiology of the postoperative stomach, and we started with the anti-reflux therapy. It means the gastric fundoplication. So I'm going to review quickly what we saw last time. So we reviewed the characteristic image after fundoplication. We review the surgical approach, okay? I'm not going to repeat it again, okay? So this is the normal Nissen fundoplication. It's just in order that you become familiar. In some cases, the wrap is filled with the contrast. This is the typical pediatric image of the gastric fundoplication. We continue. This is the CT image of a normal Nissen fundoplication. This is the endoscopic image. And we start with the complications, okay? The early postoperative complications, usually during the first months, you know that the most important is to detect the leakage. Even if when they perform the surgery, they do not open the GI tract. Sometimes leakage is an expected complication, and mostly obstructions due to the position of the wrap or just due to other complications, okay? So when we review the late postoperative abnormalities, we have to mention these in our radiographic report. So first, we have to mention if there is any mechanical obstruction, like a stricture, due to the wrap that is too tight or too long. I think we review some of these cases. Second one, we have to see the location of the wrap. The wrap should be, in most of the cases, infradiaphragmatic, but could be a migration of the wrap above the diaphragm. So we have to mention this in the report. 3, we have to mention the condition of the wrap, if it's intact or if there is a dehiscence of the wrap, could be partial or could be complete. It's not always easy to know if it's partial or complete, but in some cases it's possible. Other thing we have to mention in the report, if there is a slippage of the proximal stomach through the wrap. This is one of the most common complications after the surgery. If there is recurrence of the hiatal hernia, since this is an anti-reflux therapy, we have to mention in the report if there is recurrence of the reflux and the complications like reflux esophagitis. We have to mention additionally if there are esophageal motility disorders, okay? Just because if there is the need of reoperation, they will have to consider that in the surgical technique. And finally, and very important, if there is a short esophagus, because this is another information that is going to be very useful for the surgeon when they perform the reoperation of the patient in case is necessary. So we review these cases. This is the plain film with a filling defect. I'm not going to repeat because it was last time, the pseudotumor, okay? This is just in order that you know that this is a normal finding after gastric fundoplication. We review the leakages after the surgery. Some cases, we have several cases. This is another case. This is just review the last lecture because on CT, we can see that definitely there is a complication of the surgery, but we don't know exactly the location of the leakage. Okay, this was one of the complications that we can visualize is a too tight, okay, fundoplication. The narrowing is very significant, and you see a dilation of the proximal esophagus, and it's necessary a significant hydrostatic pressure in order that the contrast goes into the stomach. The other complication could be a too long fundoplication. Same problem. So the patient stay a long time trying to empty his or her esophagus. This is a great case we had in our department. It was a too long fund duplication, and the patient showed up, I think a couple of months after, with this obstruction here, with a filling defect that was, I don't remember, meat or chicken, something like that. So it's a foreign body obstructing the area where this tight fund duplication was. Okay, so in some cases, when you read the plain chest films or the plain abdominal films, and you know in advance that the patient had a gastric fund duplications, and you see the metallic clips above the diaphragm, you can suspect that there is a failed fund duplication. It's not 100% sure, because in some cases the surgeon on purpose leave the fund duplication in the chest, but they are very rare cases. In most of the cases, you can suspect that this is a failed fund duplication just to the migration of the clips into the chest. This is one of the complications, is dehiscence of the surgical wrap and the migration of the recurrence of the hiatal hernia, like this. This is another case where you see the recurrence of the hiatal hernia, and you cannot see the wrap there, or the stricture during the wrap. This is a pediatric patient also, where there was a migration of the wrap into the chest. Okay, on CT, you can see that this is the distal esophagus, this is the dehiscence of the wrap, this is another case with the recurrence of the hiatal hernia and the esophagus. This is the reconstruction of some of the failed fund duplication. Okay, this is one of the complications. Sometimes there is dehiscence of the wrap. We don't see any evidence of prior surgery. We see the recurrence of the hiatal hernia, and especially the recurrence of the gastroesophageal reflux. In some cases, we can see that additional to the recurrence of the reflux, we see abnormalities in the esophagus consistent with reflux esophagitis, and in other cases, we can expect to see a stricture here that in a high position may represent a Barrett esophagus. Strictures due to reflux in the high medium esophagus or in the upper esophagus probably are due to Barrett esophagus. Okay, so now we'll restart with our talk. Okay, who would like to discuss the findings? I don't have any other laser. Yes? Okay, so I have one, and I can use this one. Let's see if I... yeah? Okay. Aha. Try to describe the images, okay? This is the esophagus, this is the stomach. So you see something here. What do you think is this? Yes, there is a rounded filling defect in this position. If you know that the patient had a gastric fund duplication, maybe this filling defect is due to a wrap.
So maybe that's like a hernia?
Yes, exactly. There is a recurrence of the hiatal hernia, and I will show you an illustration. So the fund duplication wrap is intact, but there is a slippage of part of the stomach into the chest and recurrence of the hiatal hernia. Exactly. That is the complication. Yes, please. Mm-hmm.
Is it because there's not a good connection between the hiatal hernia and the rest of the gastric?
Yes, should be here.
Is the wrap too tight as well?
Yeah, could be. Yeah, it's working. It's working fine. But if you are not sure, you can ask the patient to swallow a small amount of contrast, and you will see the communication. I think it's a very smart comment, okay? So if we are not sure, if you are not sure, about how is the communication between, I have a dry mouth, sorry, between the hiatal hernia and the rest of the stomach. Just request the patient to drink a small amount of contrast and you would see it. This is a similar case. You can see the rub here, okay, in this area, the recurrence of the hiatal hernia and the gastroesophageal reflux. On CT, it's difficult. This is the same case. So you can see the hiatal hernia, but you can see the narrow here after the hiatal hernia, meaning that the rub is still intact. This is a little bit more complex because here we see the esophagus, okay? Here we see the rub that appears to be intact, but there is a slippage of the stomach in the same area in the hiatus of the diaphragm. So it's a paraesophageal herniation of the gastric fundus through the hiatus of the diaphragm. But the rub is still infradiaphragmatic and intact. Oh, this is a good case. Who would like to discuss this case?
Right, there's a
Yes.
vocal air, looks like an air fluid.
Yes. Appears to be a pouch.
Pouching.
Yes, it's a pouch.
Stricture.
Yes, so we have one stricture here and one more there. One here and one there. So which one is this and which one is that one? You see? Two strictures.
This, I believe, is post-surgical.
Yes, I agree with you. This is the rub. And this?
Could be a Barrett's, possibly?
Maybe, or could be the hiatus of the diaphragm. If you are performing this exam and you are not sure if this is or not the hiatus of the diaphragm, ask the patient to swallow the contrast and request the patient to breathe in and breathe out. And you will see that the area narrows when the patient inspirates because there is a contraction of the hiatus of the diaphragm. Okay? So, oh, I'm sorry. So this is the hiatus of the diaphragm here, okay? This is the rub. So what is this? So there is a pouch above or more proximal something like that. You see a narrowing here due to the funduplication rub. You see a gastric pouch due to slippage of the gastric fundus, but still is below the diaphragm. So this is not a hiatal hernia because it's below the diaphragm. So what is the reason for that? That we try to differentiate them because it's the roadmap for the surgeon. They should know if the esophagus is short, if there is recurrence of the hiatal hernia, if there is a gastric pouch that is below the diaphragm. Because usually this is a very serious complication for the risk of ischemia and torsion. So they have to act as soon as possible. So this is another kind of complication. This is same patient. Yes, excellent, very good. Yes. So what is this? Yes, exactly. You did it. This is exactly the illustration. So there is a slippage. The rub, first of all, the rub is intact because we can see it. There is a gastric pouch above the diaphragm, below the diaphragm, but the pouch is divided by the diaphragm, and above it is a hiatal hernia. So what is this? Lower esophageal sphincter. Okay, so this is a hiatal hernia.
Does that ever open up?
Sorry?
Does that ever open up?
Oh, yeah. This is the hiatal hernia, and this is the lower. You can see it's different here. So it's not a stricture, okay? But the question is, so it's a slippage of the stomach with formation of a proximal gastric pouch and recurrence of the hiatal hernia. This is a very rare case. This is a very rare case. Okay. Who is going to volunteer? Okay, I help you. Yes.
Likely of fundoplication, gastric pouch.
Yes, sir. But look at the diaphragm here.
So
This is the dome.
The entire gastric pouch is going through the hiatal hernia.
Okay, so we have here a narrowing of the distal esophagus due to the wrap. This contrast is inside the wrap. So it means the wrap is still intact. But if you look at the location of the diaphragm, probably here is the hiatus of the diaphragm, this is the dome of the diaphragm, all the wrap migrated intact above the diaphragm. You see? It's intact, but it's above the diaphragm. In some cases, the surgeons do this on purpose. That's the reason I tell you that it doesn't have to be 100% of the times a complication. Sometimes this is on purpose. But this is the distal esophagus that is narrowed because the wrap is still intact.
Yeah, that's what they put in loops. The problem I see in all these films is that the wrap is not in the way it should be. These are low wraps. So the idea of the wrap is to put it in the lower esophagus, in the esophagus, not in the esophagus. And these wraps, and that is because of lack of dissection. So the wrap accomplishes a pressure mechanism that mimics an sphincter, an external sphincter. Okay, that is what will happen. And the patient has physical pain and all things because of this. But these are, I think that technically they may have done the wrap low.
This is a very interesting point, and this is my opinion. This is mostly in books, but this is my opinion. Most of the failure fundoplications are due that the surgeons don't know in advance that the esophagus is short. So the anastomosis and the wrap is going to be under tension because the esophagus is too short. And the other problem they have is that they do not check the motility of the esophagus before the surgery. So sometimes the patient have a lot of dysphagia just because they cannot empty the esophagus due to the poor esophageal contractions. So if I can give you an advice, when you perform this exam, check if the esophagus is short and if there are motility disorders of the esophagus. It means the esophagus needs gravity to empty, or it can empty it by just the motility.
What objective science do you use to polish your esophagus?
It's very easy. You ask the patient in the upright position. If the esophagogastric junction is above the hiatus of the diaphragm in upright position, this is a short esophagus. And the surgeon have to know about that before the surgery, because they have, maybe you can explain better, he has to liberate the esophagus and do some techniques to lengthen the esophagus. Otherwise, it's going to be under tension and the recurrence is going to be there.
And that is the issue why the wrap we're talking about are the intra-abdominal wraps. They are intrathoracic wraps, and that is Bell-Set technique. This is the Nissen technique.
Yes, sir.
A variation. Nissen is a Swiss surgeon that in the 50s described the technique. And this technique is very effective to prevent reflux when it's not done. However, it has a problem that you put it a little too tight because of dysphagia. In the case of failure of reparation support, there is the Belsen technique, which is an English surgeon, that did the same graft in the chest. To do a Belsen operation, you go to the chest. Okay? You go from thoracotomy to the Belsen. And the wrap is done circumferentially. You pick it up, and you put it around.
Please.
I had a question, and I don't know if this is the answer or not. They don't have a wrap, you're doing an esophageal study, and you're trying to figure out if it's a hiatal hernia, like a sliding hiatal hernia versus a short esophagus. Would you tell?
If you have a short esophagus, you always have a hiatal hernia. Always.
That was my question. Like, how can you tell the difference between short esophagus or just sliding hiatal hernia?
So you can have hiatal hernia with or without short esophagus. It means that sometimes the esophagogastric junction is above the diaphragm or below. When you do not have, or you have a normal esophagus, when you perform the examination in upright position, the esophagogastric junction is going to be below the diaphragm. It's going to be above the diaphragm when the patient is in a horizontal position. Otherwise, it's going to be below the diaphragm. When you have a patient with short esophagus, it's going to be always above the diaphragm. Oh, that's okay. I try to be emphatic, but okay, so I think this is the last complication. Okay, this is one of these cases. You can, I lost my pen, my laser. Amazing. Ah, no, it's here. Oh, no. Yeah, I lost it. Okay, well, I will find it. Okay, here you have, for example, the wrap that is above the diaphragm, but still compressing the distal esophagus. It's very difficult to detect this by CT, okay? That's the reason we perform the upper GIs. Same. Okay, so once again, distal esophageal stricture, I think we mentioned this. I'm not going to back to that one, okay? So in conclusion, from this kind of surgery, upper GI allows an anatomic and functional evaluation of all these areas, okay? Pharynx, esophagus, stomach in the same exam. What is the reason this is important? Because the patient comes with dysphagia, you don't know what is the reason. You don't know if it's anatomical, if it's functional, so you have to perform one exam that tells you all the information. This is the upper GI. It's a non-invasive, do not require sedation. There are usually no contraindications, okay? If you suspect that there is a leakage, you just change the contrast for iodinated or water-soluble contrast, minimal complications, widely available. Not always there is a radiologist to perform this exam, widely available. But the equipments are widely available. It's inexpensive, okay? And it facilitates the selection of additional diagnostic procedures. For example, if you suspect that there is a Barrett esophagus, you can indicate an endoscopy with biopsy. If you suspect that the problem is motility disorder, you can suggest a manometry, okay? So you can decide, okay, what are going to be the additional diagnostic procedures based on the upper GI. Yeah, please.
Would you suggest manometry just for presbyesophagus?
No. Well, no, it depends. For if you have cleared the diagnosis that this is a presbyesophagus, usually no. But if you suspect something important, this is a very interesting question. When we should request manometry? Well, when we cannot characterize, most of the patients, all patients with gastroesophageal reflux chronic, they have motility disorders, either as a cause or either as a consequence of the reflux. Most of them. But we do not indicate manometry because we know the patient has a motility disorder. So what we do in those cases, just with the information we provide, usually they can handle these cases. So in which cases we recommend manometry? When it's a questionable case. For example, you suspect achalasia, or you suspect other severe motility disorders. So it's mostly very subjective. But in severe cases that we cannot characterize, in those cases, we should indicate manometry. But we cannot indicate manometry to all the patients that they have motility disorders. We still have some more cases. Okay, bariatric techniques. This is one of the most common, the gastric banding, okay? The stomach is divided in two parts. They create a proximal gastric pouch, okay? And there is a communication with a band here that they regulate with the distal esophagus. This is one of the surgery. This is probably the most common surgery that we see within the hospital. It's the vertical gastroplasty, okay, for weight control. Used to be a horizontal, but we don't see this very often. So they create, okay, a narrow tubular pouch that this is along the lesser curvature, and there is a communication between the pouch and the rest of the stomach. Let's see some images and some complications. This is the typical image when we perform the upper GI. This is the gastric pouch, the proximal pouch. This is the rest of the stomach. This is the area of communication. This is the same, the proximal gastric pouch. This is the area of the communication and the rest of the stomach. So this is the normal finding, okay? This is another case where the gastric pouch is larger, okay, than the previous one, blah, blah. Another case, this is more vertical. You see here the suture line. Okay. So CT, I'm going quick because for the time. Okay. What is this? After surgery. Immediately after surgery. Leakage, of course. This is a leakage, okay? So when we suspect leakages, we always use water-soluble contrast.
Is that a gastric sleeve or a vertical handicap?
Well, I don't know. This is the stomach, this is the pouch, and there is 1, 2, 3, 4. What's amazing, looks like a fountain. Plenty of leakages, okay? This is one of the images. I have a beautiful sequence from the one to this is probably one of the last ones, where you could see leakages everywhere. The CT was also very abnormal. This is another picture of the same patient after the treatment, follow-up. Mm-hmm. So this patient lose weight, definitely. Okay, this is another leakage. Okay, this is the gastric pouch, this is the rest of the stomach, and there is another leakage after the surgery. But in other cases, this could be a different complication. This is the esophagus, this is the proximal gastric pouch, and what do you think is the complication? Yes, there is a stenosis of the communication between the proximal gastric pouch and the rest of the stomach. If you perform this examination immediately in the postoperative period, usually this is something expected due to edema, due to hemorrhage. But when this is several months after the surgery, definitely there is a stricture. There are many causes of strictures, but the most common is scarring. Okay, this is the most common. Okay, let's go to another topic. I think we have time. 50. Okay. So this is a technique we have to know because we receive many patients to perform this exam. This is the distal gastrectomy with gastrojejunal anastomosis. It's also called Billroth I, or with gastrojejunal anastomosis. Okay. This is called isoperistaltic, and this is antiperistaltic. And this is the other kind of gastrojejunal anastomosis that Rooks and Y. This is the we have to become familiar in order to understand the images, okay? Indications, surgical technique, is very easy to, you can review in many books. Okay, the typical image is this. So you see part of the stomach, this is a ballistic fragment. This is part of the stomach, the proximal stomach. This is the area of the anastomosis, and this is the small bowel. Sometimes the technique is not easy to perform because this area is a little bit narrow. But we have to wait, and in some cases we have to put the patient in upright position in order to see the contrast flowing from the proximal stomach to that area. Okay. Who is going to describe this image? Yes, it's a single contrast. This is Billroth I. It means this is the duodenum. Yes. Exactly. So one of the differential diagnoses, if this could be pouched left by the surgeon, but it's extremely rare that they left something like that. So we perform a double contrast examination of the same patient. Could be, but maybe we can find something that explain all the images. I'll give you a clue. So what we see here is a deposit of contrast, and all these are converging folds. So when we see multiple converging folds, that they are not due to the surgery, probably there is an ulceration there. And this is an ulceration in the area of the anastomosis. So this is one of the complications. So this patient had a stricture, as you can see, because it was difficult to move the contrast from the stomach into the duodenum due to a ulceration in the esophago-duodenal anastomosis. Sorry?
It's not esophago. The anastomosis is antro.
Yeah. This is the antrum, and this is the duodenum. Yeah, gastro-duodenal anastomosis. Sorry for if I said something wrong. Okay? At this level. It's the same case.
The outpouchings are created just due to the increased pressure because of the stricture?
No. There is a, due to the, okay. When you have an ulceration, you have scarring. And the scarring produces traction. This is the traction due to scarring that is generated by the ulceration. Scarring produces converging folds, and in severe cases, strictures. That's the reason when you see, for example, a duodenal ulceration or an ulceration of the duodenal valve, you expect to see these multiple outpouchings, that they are due to multiple areas of scarring. Okay? Scarring is the process that produces these images. This is another case where you can see the proximal stomach. This is the duodenum, and you can see a deposit of contrast here with some converging folds. This is another case due to a deep, large ulceration at the level of the anastomosis. Billroth II. It means Gastrojejunal Anastomosis. What do you think about these images? This image, sorry. Okay, this is the stomach, This is the esophagus. This is the small bowel. Do you think the communication here is normal?
There's narrowing. I'm sure.
Exactly. So there is narrowing of both sides of the anastomosis. Both sides, sorry, of the small bowel. Okay, this is probably due to scarring. Yes, I think so. Yes, I think so. I don't know because I couldn't.
Yeah, because Intus are done nowadays, for gastric cancer, they could be a recurrence. That's the most common cause of local recurrence. Local recurrence in gastric cancer goes to the celiac cancers and anastomosis. One thing I want to say about all the both of you presented, Alberto's. I just come from a meeting, it was excellent quality of people from the ACR, the American Society, and the French Society of Radiology. And I've seen a lot of presentations. I can tell you, our presentation here are superb, for all of you. The quality of our presentation, the gentlemen here too, is superb. Because all of them, all our faculty are presented internationally. But I can tell you, compare what I have seen thinking back yesterday, this is wonderful. Congratulations.
Okay, so this is the anatomy, and yeah, definitely there is a stricture due to scarring at the level of the anastomose.
How can you tell that's isoperistaltic? Do you watch?
Yeah, if you don't see this part, it's no way to know. I don't know.
Okay, well, but your afferent limb is up in, is it right across?
I don't know. In this case, I don't know if it's isoperistaltic or antiperistaltic. I don't know. If you don't see the rest of the anatomy, personally, I don't know how to make. But definitely there is a stricture there. Okay, so the surgeons should know about that. This is one of my not biggest mistakes, but it's one of my mistakes. A case I remember always because I made a mistake. Okay, so since this was one of my mistakes, I will mention. This is the proximal stomach. This is the area of the small bowel. And I found very irregular this area and a large filling defect here. Okay? So I said, wow, this is a tumor. Okay? What else? Okay? Filling defect at the level of the anastomosis, I went for tumor. So they perform a CT. And look at the CT. What is this? Filling defect due to. It's an intussusception. This is due to an intussusception that produced this filling defect.
Look at the foot defect, some of the folds and things are.
Yes, exactly. I agree with you. That was my mistake. I was obsessive. I said, finally I found a tumor. And I forgot that the folds were normal.
How far from the surgery was it, Roberto?
Eh?
How far from the surgery?
I don't remember. I don't recall.
No, really, let me correct a little bit. It's a misdiagnosis.
Yeah, it's a
You know the
misdiagnosis.
abnormality, but you interpreted not what it really was. It's a misdiagnosis.
So we performed the CT, we performed the coronary contraction, the axial recontraction.
You know there's a problem.
Oh, yeah, okay, thank you.
You misinterpreted.
Yeah,
It
okay.
needs a scope.
I don't think so. When I saw the CT, immediately we recognized that, you see, there is no mural thickening, no any other abnormality. So I don't think there is a differential diagnosis for.
I've never seen.
And I think that
This
I don't know
is
if we
the-
have to consider this an error in the diagnosis, because if you have 10 cases like this, probably you will say again, tumor
Nine
is the
times out of 10
first option.
Yeah, no, I just comment that sometimes we make mistakes.
No, but based on the imaging findings and the filling defects, always in a patient with history of cancer, I would say the first thing to consider is recurrence.
Yeah.
Okay, so you see here the.
Right, most of the
No,
time.
it's a zebra. This is a zebra.
Good job, Dr. Good job.
Okay, so total gastrectomy, this is very quick, okay? Roux and Y. So we have to become familiar with the esophago-jejunal anastomosis, okay? And this is the typical picture when we perform the fluoroscopic exams. This is the esophagus, this is the small bowel, it's an end side, okay, anastomosis. This is the jejunum, okay, here. And I will show you a few cases with complications. This is the last part. This is one of them. So you see the stomach here, okay, and you see a stricture here, okay? So you see how difficult it is for the contrast to go from the stomach into the small bowel, or the jejunum, okay? So stricture at the area of the anastomosis due to scarring.
Is that residual cardia?
This here.
Is
This?
that cardia?
This?
Yeah, that blob, that little.
That outpouching right there.
Yeah.
Ah, please.
Is this residual cardia?
Yes, yes,
I
yes.
would be very much concerned when you see those lumps there.
Yeah, I made a mistake. I said the stomach, and it's
Or
really.
malignancy. I would be very much concerned when you see tissue growing into an anastomosis or malignancy.
Okay, and I have other cases. These are two.
Was that a recurrence or was it already?
No, was not recurrence.
What was the nodule?
Was benign?
This was benign, but I don't remember the reason for the surgery.
Did you have endoscopy?
This patient, I don't recall.
But no, the reason being, this is important, because you see a tube, you see a mass growing into the lumen.
Mostly this is due to
No, in the bottom. Look at the bottom.
here,
Yeah, no, that's.
Like the one on top.
Yeah.
That-
here. Ah, okay, this area.
What I'm saying,
yeah.
not to be picky, but in reality,
No, that's
I understand
okay.
what it is. It could be a technical defect. However, all this anastomosis nowadays are done with staples. They're not done kind of so. You know?
Right.
And it would be interesting to see what is that tissue.
Yeah, radiographically, if of course we are going to wait for the endoscopy, but if you would like to guess if this is a recurrence or this is something post-surgical, the best way is to apply different degrees of distension. When this changes the shape, maybe it's post-surgical. If it remains exactly with the same shape, probably it's an area of scarring due to a tumor or recurrence of the tumor. This is other cases we have here, very similar to the previous. This is another case, okay? This is another case. This is a dilated esophagus, okay? This is the area of scarring with converging folds. Okay, so in conclusion, when we have total gastrectomy with the esophago-jejunal anastomosis, what we have to check? Well, in the early postoperative period, the most important, leakage, and leakage, okay? Could be also anastomotic obstruction, but the early postoperative period, you don't have to be worried about. Okay, could be leakages from the duodenal stump, but we have to detect it usually by CT, same as leak from the jejunal anastomosis in cases of Roux and Y. And in the late postoperative period, anastomotic narrow could be due to ulcer scarring, fibrosis, or as Dr. D'Agostino mentioned, recurrence tumor. Also could be also some cases with reflux esophagitis. That's it. Next month, duodenum.